good afternoon to all of you. And here we are back again, starting today's topic, which is thalassemia. As you might all know, that this is a thalassemia month, which is a thalassemia awareness month. And what we are trying to do over here is it's a particular disorder of blood, which we will hear from our guest speaker today. But what is very important over here is that India is one of the countries where this particular genetic condition prevails very highly, and it's one of the government projects also to screen every person before pregnancy, because there is a very high risk of having a child with thalassemia. But we should also understand that there are different kinds of thalassemia, and just being a carrier does not mean that you can have a child who is affected. There are different forms of thalassemia, and hence it is very important to understand the exact, the combinations which works and the combinations which don't work. Without much ado, I will introduce our guest speaker today. Our speaker today is Dr. Prosanto Kumar Chowdhury. He is a consultant hematologist and transfusion medicine. He is at the Institute of Child Health, Calcutta, and he is also there with Peerless Hospital and BK Roy Research Center. He's the director and laboratory in charge of Cord Life Sciences India Private Limited, and in charge of research and development and innovations. Sir has a huge number of publications and accolades with that, and he's the perfect person to give the talk today. So that is why we welcome you, sir, for the ORDI Rare Info Series on thalassemia awareness.
Thank you, Dipanjana. I hope I'm audible for such kind words. Just for a small clarification, I'm not a hematologist. I have done my master's specifically in hemoglobinopathy and thalassemia from the University College of London. So please don't consider me to be a hematologist. I think I understand a bit of RBC.
Sorry, sir.
Nothing more than that. Sorry. Okay, so as Dipanjana has already set the tune for this particular meeting, I think it's on thalassemias and hemoglobinopathies. By itself, it's a very big topic, but let me see how we can make it a bit simpler and we can take it through to everybody who's present. So, what are hemoglobinopathies? Hemoglobinopathies are a group of inherited disorders of hemoglobin. So what is hemoglobin?
Excuse me, sir, you are actually on a dual mode. If you could switch on to the slide share mode, I think the display needs to be changed because we cannot see
Has the slide changed now?
The slides are changing, sir, but the display setting is that of a projector. So if you could just change it to like a single screen, that would work. You have to change your display settings. Yeah, yeah, that one. Correct.
This one, okay. So this, now is it okay? Okay, display settings, just a minute. Duplicate slideshow, right?
So, sir, swap presenter view, sir.
Okay. Is that okay?
Yes, sir. Thank you.
Okay, thank you. So what I was trying to convey to you is that hemoglobinopathies are a group of inherited disorders of hemoglobin. So hemoglobin is the oxygen carrying protein which is present in the blood, and such hemoglobinopathies represent the commonest monogenic disorders worldwide. So as we all know that the hemoglobin is actually consists of two parts. One is the globin protein and the second is the iron part, which is the heme. So the globin protein, if it is broken up, there are two types of globin proteins present. One is the alpha globin protein and the second is the beta globin protein. The alpha globin protein is actually coded for in the chromosome number 16 and the beta globin protein is coded for in the chromosome number 11. So now what happens is if there is a defect, now what happens is they are synthesized almost equal to. So now if they're synthesized, at a particular proportion which is physiological, they balance each other out. Now, if there is less synthesis or no synthesis of the beta globin chain, then what happens? The excess alpha chains precipitate. If there is alpha chain is synthesized normal and the beta globin chain is synthesized in excess, even then the beta chain will precipitate. And if the alpha chain is not synthesized, the beta chain will be synthesized in excess, and that will precipitate. What does it precipitate on? It precipitates on the red cell membrane. And this red cell membrane undergoes an oxidative interaction, and the red cell membrane breaks up. This breaking up of the red cells gives rise to the destabilization of the red cell. And these red cells, once disrupted, cannot take the oxygen along with it. Therefore, what happens is there is in the periphery, in the bloodstream, there is less blood and it carries less oxygen also. So that gives rise to an anemia. And this anemia primarily is due to reduction of hemoglobin, which is due to the breaking up of the red cells. That is why we call this a hemolytic anemia. So as this, I was telling you that this is a disorder of imbalance, means there is an imbalance between the beta and alpha chains. So there might be two types of defects. One defect is there is an globin chain which is absent or is synthesized less. Then again, this balance gets disrupted, and this kind of quantitative defect of the globin chains giving rise to hemolysis, which is giving rise to anemia, is taken under thalassemias. And number two, if a globin chain is synthesized with some defect, which might precipitate under certain conditions, not under normal conditions. It might precipitate when there is acidity of the blood, when the blood becomes acidic. It might precipitate when the blood becomes a bit alkaline, or it might precipitate when there is less oxygen in the blood. These precipitation of the hemoglobins actually compromises with the deformation capacity of the red cells. And this deformation capacity of the red cells, if compromised with, or in other words, if the hemoglobin also precipitates, what happens is they give rise to anemia, because these deformed red cells, they get entrapped within certain very small capillaries, and then it breaks down. That gives rise to anemia. The commonest example of such kind of qualitatively defective hemoglobin is sickle cell, that is HbS. There are other types of hemoglobin defects like HbD, HbC, HbE, and there might be composite hemoglobin defects, that is one person having two types of defects. One will be a quantitative defect, that is a thalassemia, and the other chain might be defective as far as the qualitative chain is concerned. So we can have sickle beta, E beta, delta beta. These kind of combinations keep on occurring. So these are the compound heterozygous states. And these are inherited as an autosomal recessive pattern. Now, the first type of thalassemia that we all know of, this is a particular disorder which was discovered by two scientists by the name of Dr. Cooley and Professor Lee. They were pediatricians in Detroit, and they could identify certain children who had migrated from Italy, Sardinia, Greece, Turkey to the United States. And they had children who were starting suffering from anemia from 4th month or 5th month of age. They developed a big abdomen, which was due to the increase in the volume and size of the liver and spleen. And after that, they developed heart failure and they died. He described this particular type of anemia as a non-spherocytic hemolytic anemia. And think of it that when this thing happened in around 1925-26, we did not know much about the hemoglobins. We could just see the size and shape of the red cells under a pretty crude microscope, a magnifying agent or a magnifying instrument. We did not have a compound microscope at that point of time. And once they said this, there was a publication in New England Journal of Medicine, and this described this particular type of disorder, and they thought that it was due to a disorder of hemoglobin. And this particular disorder was named after them in the United States by the name of Cooley's anemia. After that, it was named as thalassemia because most of the people, most of the children who were suffering from this particular disorder or a disease, I would rather call it a disorder rather than a disease, their fathers and mothers had migrated from Italy, Sardinia, Greece, Sicily, Turkey, and all these places. And these places were actually surrounding a particular water body, the Mediterranean. So they called it thalassemia, where thalassi means a mass of water and mia means blood. So thalassemia actually meant a disease or a disorder which occurred near a mass of water. Here, the mass of water is in the Mediterranean. Now, they had classified this particular disorder as thalassemia major. That means the people who were having a very high quantum of defect in their body. They could not synthesize normal hemoglobin at all. Therefore, they had to survive on very frequent blood transfusions from normal individuals. And that is why they called this disease a major. If they required a bit of less transfusion, they called it a intermediate disease, which is of intermediate. So what happens here, after we knew the genetic basis of thalassemia, as there were no normal genes that were synthesized, we called it beta 0, or it could be a beta 0, beta plus, where what happened is the severe part, it is very severe. It generally presents at around 6 months of age and it requires lifelong transfusions. And it is currently called as transfusion dependent thalassemia. There is another type of thalassemia where the people who are suffering, they generally require transfusions at an interval of either equal to or more than 3 months. They were called as NTDT or non-transfusion dependent thalassemia, where there is a milder type of beta plus mutations or there is co-inheritance. The clinical severity is moderate and they do not require transfusions or they might require occasional transfusions. The third state was a beta thalassemia carrier, which is not identified by a person from the external appearance. It is the heterozygous state where one gene is normal and that goes on synthesizing almost normal amount of hemoglobin, just that the rate of synthesis of the hemoglobin is a bit slow. Therefore, they might be having normal hemoglobin, they might be completely asymptomatic, or they might have mild anemia. And if a person is supposed to be proved to be having a thalassemia carrier status, that person will never or will ever never require a blood transfusion. And there are compound heterozygous state. The commonest type present in India is HBE beta thalassemia, which is a compound state, which is a compound heterozygous state. There it might be mild to severe. It is very highly variable and the transfusion requirement is highly variable, because you do understand that this beta is the spoil sport and the most contributory factors towards transfusion dependency. So if it is a E beta 0, generally the person will be requiring transfusions. But if it is a E beta plus or a E beta plus plus, then the person might not be requiring transfusions or might be requiring very infrequent transfusions. That is why the transfusion need has been written as variable. So what is the global epidemiology? I'm not going to go into the detail. There's a highest prevalence. It used to happen before. This is what we studied when we became doctors. It is said that it is present in the Mediterranean, Middle East, Central Asia, Indian subcontinent, Southeast Asia. But currently, there is not a single continent in the whole of the world which is bereft of thalassemia because of movement of the population from one part of the continent or one part of the world to the other. I remember when I was going through a particular diploma course in Cyprus, there was a lady doctor with me who had come from Germany. She said that she hasn't seen a case of thalassemia in her life. And this is way back in 1996. There was no thalassemia patient in Germany. At that time, it was West Germany. And she told me that their health regulators had sent her to this particular workshop because they wanted a doctor to get trained in thalassemiology, such that if there is a migration of patient to that particular place which is currently not having any thalassemia patient. They'll be able to take care of them. And you can imagine the foresight that the people in Germany had. And now even Germany has got a good amount of thalassemia patients. None of them are indigenous, but it is totally due to the migrant population. The carrier frequency reaches about 50% in some communities. It is there in the northeast of India, and about 48% of HBS, that is sickle trait, is present in tribal populations. And the migration of him has led to the spread of hemoglobinopathies to previously non-endemic regions like Northern Europe, America, and Australia. WHO estimates that only 12% of the transfusion dependent thalassemia patients globally receive optimal transfusions. That means the developing countries, the Africas, they do not have access to a particular, what should I say, the state of art therapeutic facilities that is available in the developing and the developed countries. So the survival out there is pretty low. So I'll go to the next slide. So this is what was previously known as the thalassemia belt. You can see it spreads from the peri-Mediterranean countries, that is Spain, Egypt, then there is Italy, there is Cyprus, there is Greece, a part of Egypt. Then it comes to the entire Middle East, Pakistan, India, Bangladesh. It spreads through Myanmar, Burma, and again to the entire Indonesia and Malaysia. So this is known as the entire hemoglobinopathy / thalassemia belt. What is it like in India? In India, these places have got a very high prevalence of thalassemias, mainly Rajasthan, Gujarat, these places, and Punjab. There are migrations which have happened to West Bengal, and the places in this particular area, that is Maharashtra, the western part of Maharashtra, the whole of Madhya Pradesh, Chhattisgarh, Odisha, Jharkhand, and a greater part of eastern West Bengal have a very high prevalence of sickle cell hemoglobin. This entire northeast, like Arunachal Pradesh, Assam, part of northern West Bengal, has got a very high prevalence of hemoglobin E. So you can see that the entire India, just leave aside a bit of Tamil Nadu and Kerala, entire India, except for a bit in Jammu Kashmir, the entire bit of India has got some type of thalassemia and a hemoglobinopathy population, or a mixture of both. So much so for the epidemiology. And today, I don't think I'll be incorrect if I say India, it has now become the thalassemia capital of the world. The patients living with thalassemia, transfusion-dependent thalassemia, varies between 1 to 1.5 lakh. The population of beta thalassemia carrier is around 42 million, and the annual birth rate of children, or very small children with thalassemia major, is about 10,000 to 15,000. I'm not going to go into the statistics. As Dipanjana had said, that there has been a government initiative where 15.8 lakh individuals have been screened under the National Health Mission, and about 50,462 carriers has been identified. And this statistics is as of there in March 2025. So commonly it is present in Sindhis, Punjabis, Gujaratis, Bengalis, Mahars, Kolis, Sarasats, Lohanas, specifically the Kachi Lohanas and the Gaurs. So I'm going to the next slide. So now comes the question, how to diagnose thalassemia. So the thalassemias can be diagnosed by a complete hemogram and from a peripheral blood smear, generally microcytic hypochromic anemia with target cells with elevated red cell count. So this is where we differentiate, because if there is anemia due to the commonest disorder, that is iron deficiency, the red cell count would be low. Though there will be microcytosis and hypochromic anemia, there will be target cells, but always the red cell count is low. But if the red cell count is high and there is microcytosis and hypochromia with target cells, almost 99% you are dealing with a beta thalassemia carrier. And if we do iron studies, that is serum iron, total iron binding capacity, percentage soluble transferrin saturation, and serum ferritin, that is the iron storage protein, we'll be able to know, we'll rule out iron deficiency from these cases which have been suspected, and then we can at least confirm that these are thalassemias from these two studies. Till now, the gold standard is a hemoglobin HPLC, which is also known as the high pressure liquid chromatography, where if we quantify the different types of hemoglobins which are present in an adult, that is hemoglobin A, hemoglobin A2, and hemoglobin F fractions, and other structural variants, we'll be able to identify if a person is a thalassemia carrier, or most of the times if the person is normal or is a carrier or a patient of certain hemoglobinopathies like hemoglobin E, hemoglobin S, hemoglobin D, etc. And of course, the confirmatory test is doing the genotyping. So if we do a gene test, I will come into that later. So if we do the gene test, will be confirmed if a person is suffering or is a carrier of thalassemia or not. Just one thing to remember, HPLC first approach is the most cost effective, but as a clinician or as a person who's treating thalassemia patients since a long time, since 1992-93, I've come to realize the HPLC at that point of time was not there in India. We had done a lot of electrophoresis at that point of time. And again, automated instrument churning out an RBC indices, which is correct for a CBC, was again not there very much. But later on, we realized that if a complete hemogram, that if a CBC is done along with HPLC is done, that brings down the false rating of a false reporting of an HPLC and a CBC to almost 10 to 15%. So if we can do that, then if we do both together, we will possibly not miss, but we will get some ambiguous report, which will have to be confirmed through genetic testing. Because we live in a country, or we live in a part of the country where hemoglobin E is very common. Hemoglobin E can just be picked up by HPLC. It cannot be picked up by CBC alone. So that is one where we miss the hemoglobinopathies. And you'll also understand why genetic testing is important, because as I told you that it is a game of balance. So if there are three genes, actually there are four genes for alpha. If there is a gene triplication which happens, there are six loci, or there are five loci which is synthesizing the alpha globin gene. Then what happens? The alpha globin gene is synthesized so much in excess that even if there is a normal beta chain, or if the person is a beta carrier, that means there is deficiency in one chain, this can precipitate a person to have a trait, from a trait or a carrier to a disease. That means if a beta carrier has an alpha gene triplication, that is per individual is going to behave like a disease. And this alpha triplication cannot be detected if we do not do a genetic testing. So about 20% cases also, if the person has a single mutation on a standard DNA testing, it might show a single mutation because of certain technical drawbacks of interpretation of the yesteryear's genetic testing. But today the genetic testing has also become pretty robust. So if we do a stepwise genetic testing, we will not or should not miss any cases. So this is what I was telling you. So these are the main hemoglobins which are there. You can see these are the HPLC strips which have been churned out from one of the very renowned and time-tested HPLC instrument. And these are the hemograms which have been churned out. So here you can see this person is having a hemoglobin of 13.6. A hemoglobin of 11.6. The red cell count is 3.6. Hematocrit is 34.4, but the MCV is 95.3 and the MCH is 32.2. So in this person, if we apply a rule of three, the rule of three actually works. So if the rule of three works, then this person is not a carrier or a patient of thalassemia. Whereas a person having a hemoglobin of 12.6 with a total RBC count of 5.8 has got an MCV of 63.8 and an MCH of 21.5. Here, the hemoglobin of 12.6 has got an excess red cells. So this, with the microcytosis and hypochromia, you can almost conclude that this is the complete hematogram of a beta thalassemia carrier individual. So this is the HPLC of a normal person. Here you can see what we judge here is the level of adult hemoglobin, which you can see here is 94.6. The fetal hemoglobin level is 0.2 and the hemoglobin A2 level is 2.2. This, if is within 3%, it actually signifies a non-carrier status as far as beta thalassemia is concerned. So here we have got another chromatogram where the hemoglobin A0 or the normal hemoglobin is 78.6. Hemoglobin A2 is 5.9. This is a hemoglobin A2 peak. It is 5.9. So here you can see that the A2 is high, which has come up to 5.9. So this is a chromatogram which actually belongs or which should be classified as a beta thalassemia carrier where the fetal hemoglobin is normal, that is 0.8. Here you can see that the A2 is 2.2, adult hemoglobin level is 5, whereas the fetal hemoglobin level is 92.8. So this is the chromatogram which is typical of a thalassemia, beta thalassemia patient. So this is that of a normal person. This is that of a beta thalassemia carrier because here the A2 is high. It is more than 3.5, which is the cutoff. If the level of A2 is between 3 to 3.5, it should be dealt with as a suspicious state. You should do the iron level, and if the iron level is low and the hemoglobin is low, then with iron supplementation, let the hemoglobin increase to almost normal levels. Then a repeat of this particular test should be done. If the hemoglobin level is between 3 to 3.5, do a repeat HPLC, then you'll be able to see the actual HPLC level. Here, the A2 level is normal, but the hemoglobin A0, that's a normal hemoglobin, adult hemoglobin is low, but the fetal hemoglobin here is high, which is a compensated state of the fetal hemoglobin synthesizing cells. And this is the typical picture of a thalassemia patient. This is another picture which we very commonly see in this part of West Bengal and in Northeast India. Here you can see the hemoglobin A2 level is 77. So this hemoglobin A2 is not totally contributed by this hemoglobin E2. It has got a hemoglobin E peak with it, and both of them have got superimposed. Like you see my hand here, my second hand is here. So vertically you can see only one hand. But if I remove it, you can see two hands. So there is overlapping of the hemoglobin E with A2 levels. So that is why it has increased. So this is a state where the fetal hemoglobin is almost normal. This is a state of homozygous E, or some people call it an E disease. So these are the four types of chromatograms which I have discussed with you, with two types of complete hemogram reports. This is that of a person who's normal, though the hemoglobin might seem low. This is that of a normal, because if you see the MCV, you can see that the MCV is almost normal, and the MCV is normal, then the MCH is normal, and 3 times the particular hemoglobin, if we the red cell count we do, it is corresponding with that of the hemoglobin level, and 3 times the hemoglobin level is corresponding almost there with the hematocrit level. Here, if you do 3 times the red cell count, it is going to exceed the hemoglobin. So if that happens, then this is 3 into 5.8, that is 15, whereas the hemoglobin is 12.6 or 12. So the rule of 3 does not apply here. So this must be or should be from a thalassemia, beta thalassemia carriers complete hemogram report. So I've already explained to you this. So if the MCV report shows that it is less than 80 femtoliters and the MCH is less than 27 picogram, there is an elevated red cell count, blood smear shows target cells and hypochromia, and the Menzer index, that is MCV by the RBC, it is less than 13, you can almost conclude that this is a case of beta thalassemia carrier. You can go in for reticulocyte count, and you must distinguish it from iron deficiency anemia. So the take home is here, HPLC and HB electrophoresis, though it is considered the gold standard, but still to me, we have got 15%, up to 15% ambiguous reports on HPLC, which requires to be resolved using which requires to be resolved using a genetic testing, where if the person is a beta thalassemia carrier, he or she will have a hemoglobin A2 which will be more than 3.5, typically between 4 to 6%. If the person has a hemoglobin A2 level of between 3 to 3.5, it should be dealt with caution. If the person has got a hemoglobin A2 level of less than or equal to 2.1, even that should be treated with caution and genetic analysis should be done. Beta thalassemia major will have a HbF of 60 to 90% and hemoglobin A would be absent or reduced. Here there is another variant known as HPFH. If you get an adult or a person who's more than 2 years of age and having more than 60 to 90% of fetal hemoglobin, possibly it is not a case of beta thalassemia major. It might be a thalassemia major type of presentation, but it might be a patient who's suffering from something known as hereditary persistence of fetal hemoglobin. So that is important. Hemoglobin E, I have already talked to you. Hemoglobin S, I have talked to you. HPLC, though it can detect alpha thalassemia variants, please do not go by this. If a person has alpha thalassemia variant, only a hemoglobin H can be detected. In some cases, most of it is cannot be detected. HPLC today is the most cost-effective universal screening tool, and it is also recommended as the first line in the antenatal screening. Next, if we go into the genetic analysis for alpha globin deletions, now there are alpha globin mutations also. There is a gap PCR which is done. Then also MLPA is also done for alpha globin deletions. First, there is an ARMS PCR and a DNA sequencing which can be done for beta mutations. MLPA is also done for rare deletions and duplications. And now the talk of the day is next generation sequencing is done for complex cases. The essential type also is required for genotype-phenotype correlation. And there is also a future patient-specific therapy when we want to give, we should also do molecular genetic testing. Why? I'll come to you later. And when I was a student, I used to see this type of a picture in our textbooks where we used to memorize a mnemonic saying thalassemia. The spelling is Thalassaemia. T would stands for transfusion dependence, H for hepatosplenomegaly, A for severe anemia, low for low MCV and low MCH, A for abnormal facies, that is this chipmunk facies, S for skeletal deformity and S for stunted growth, E for elevated hemoglobin F, M for Mediterranean region, I for iron overload from transfusion, and A for amenorrhea. Though amenorrhea was not the only one, it is covering the entire endocrinal complications. So now I'm going to talk to you about the treatment or the management of thalassemia that we give today. So the management today that it is given, it is comprises of actually two parts. One is blood transfusion and the second is iron chelation. Blood transfusion till date is the cornerstone of transfusion-dependent thalassemia. It requires regular red cell transfusions, and we want to maintain a pre-transfusion hemoglobin level of around 9 to 10.5 gram per deciliter. Iron chelation therapy, we will come to you later. There are certain agents which today are being tried to reduce the transfusion load. Hydroxyurea is one of the primary agents. It reduces the transfusion need in selected patients. And the emerging agents, though thalidomide, I will not put under emerging agents. Plenty of clinicians are using thalidomide now. Mitapivat is undergoing clinical trials, which is classified under the 2A or 2B trials. Class 3 clinical trials is yet to start on mitapivat. And there are certain curative therapies like hematopoietic stem cell transplantation, which is established cure, gene therapy, and gene editing approaches. So I'll deal with them in a bit of a detail. So the blood transfusion therapy, if we see an individual who on two separate occasions as having 15 days apart has got a hemoglobin level of less than 7.7 grams, the person should be started on regular transfusion. The transfusion frequency would vary between 2 to 4 weeks. Ideally, a leukodepleted phenotype matched packed red blood cells should be transfused. we should maintain a pre-transfusion hemoglobin level, which should not be less than 10, which should not be less than 9, and also should not exceed 10.5 gram per deciliter in pre-transfused individuals. The volume should be calculated between 10 to 15 ml per kg. 15 ml per kg to 10 ml per kg should be adjusted against the hematocrit of the blood transfusing unit, and the post-transfusion hemoglobin should not exceed 14 to 15 gram per deciliter. What are the complications of chronic transfusion? Iron overload, alloimmunization, but this alloimmunization reduces if the phenotype matched packed red cell is given. Transfusion reactions is also get reduced when you give leukodepleted, even washed packed cells with phenotype matching. Infection risk, if the blood is screened for all the TTIs, that is the transfusion transmitted diseases, the infusion risk decreases. Venous access is a practical challenge because all the thalassemic individuals, they get punctured in the same vein since they were 4 or 5 months of age. To our patients who've now at least attained 45, 50 years of age, the same 4 or 5 veins are being punctured regularly. So the venous access and the venous care should be taken. Due to low transfusion requirement or low transfusion being given, the spleen size increases. And as the spleen size increases, the transfusion requirement also increases. So if the transfusion requirement is more than 200 to 220 ml per kg per year, then we should consider cutting of the spleen surgically or splenectomy. In iron chelation, each blood unit actually adds 200 milligram of iron to the body, and the body cannot physiologically excrete iron. So we have to give some medicines with which we are able to excrete the iron out of the body. The first medicine that was discovered in 1960s was desferrioxamine. It has got no oral route. Subcutaneous and intravenous infusion is required. The infusion should be given over 8 to 12 hours, at least 5 to 7 days a week. The dose varies between 25 to 60 milligram per kg. Deferiprone was the drug which actually went through a clinical trial when I was an intern or a house staff. This is one company makes this in India by the name of Kelfer. This is an oral agent, though it is a weak chelating agent. It has to be given 8 hourly. The dose is between 75 to 100 milligram per kg. But we have seen combination of desferrioxamine and deferiprone. We call it desferal and kelfer. If they're given in a combined way, then there is a shuttle hypothesis. This shuttle hypothesis excrete more iron than they can individually do. And we used to get pretty good iron status with the combination therapy in the era where the deferricidox was not discovered. Again, deferricidox came into being. It was marketed by Novartis. It is a discovery product of Novartis. Once this came into being, this particular drug actually changed the survival of all the thalassemics and their compliance towards chelation. So this is an oral drug. It has to be taken daily, once daily, and the dose varies between 20 to 40 milligram per kg per day. Let me deal with the individual drugs. Desferal has got, if it's an injection, it has got local toxicities due to injection. There are hearing and eye vision problems, and there might be growth failure. With deferiprone, there is lowering of the WBCs and platelets, and it can give rise to GI disturbance and arthralgia and arthritis also. The deferricidox can give rise to agranulocytosis and to thrombocytopenia. The platelet count might come down, and the most important side effect of this is hepatotoxicity, GI toxicity, and renal toxicity. So once we give these drugs, now desferal infusion has almost stopped. But if a person is being given desferal infusion, desferrioxamine infusion, it also has got renal side effects. So ideally, a person with a compromised renal function should not have a dual chelation with desferrioxamine and deferricidox, because both of them have got same side effects. So deferiprone, if it is given, ideally weekly CBC is requirement. but our children or our health system cannot afford the expenses of a weekly CBC. Therefore, we do a CBC on a compromised basis at least monthly. The creatinine level, the microalbumin creatinine ratio, and the liver function test also has to be done monthly if a person is on deferoxamine. And also there should be annual audiological, ophthalmological, renal tests which should be done when the people are on these agents. I'm not going to go into combination therapy because this is a specialized field by itself. Ferritin, I'm not going to go into this. All these tests are supposed to be done, and growth monitoring is also very important when we talk about chelation therapy because they also contribute to stunting of growth, especially with desferrioxamine. But desferrioxamine now, as it is very sparingly used, we really do not get desferrioxamine toxicity precipitating stunting of growth now. So what are the fetal hemoglobin induction therapies? So we've got some therapies in the form of hydroxyurea. Though it is a pharmacologically accepted agent for sickle cell disease, it is now being used for non-transfusion dependent thalassemias, especially HB beta thalassemia. The dosage varies between 5 to 20 milligram per kg. Response generally occurs between 10 to 20 milligram per kg. It can reduce transfusion requirements by 30 to 50%. Again, this particular drug causes myelosuppression. That means the WBC and platelet count might go down due to this drug itself. Therefore, a monthly complete hemogram to be done is a mandatory when a person is being treated with hydroxyurea. Other emerging HbF inducers, one is thalidomide. The dose I'm not going to go into because this is still very experimental. Some take it as a non-responder for hydroxyurea to be given thalidomide. Some people use combination therapy, but it is entirely up to the person who's treating the patients. There are other short chain fatty acids like butyrates. These are epigenetic modulators. They are also being used. And also some antioxidants like vitamin E is also being used for inducing fetal hemoglobin, which might or might not work in certain individuals. Luspatercept, it has been approved and it is being marketed in India under the name of Rosusda. This enhances late-stage erythropoiesis. It reduces the transfusion burden by almost 33% in around 21% of TDT or the transfusion-dependent thalassemia patients, and it has to be given by subcutaneous injection every 21 days. Mitapivat is a phosphokinase activator, and it actually, pyruvate kinase activator. So this is an oral drug. It improves RBC metabolism and it also reduces hemolysis. It helps in the oxygen carrying capacity of the red cells. So it has shown clinical improvement in NTDT, but its study under transfusion dependent thalassemia is still under observation. Once this comes out, we will know and we might be able to use it. So now before this, we've said that due to iron overload, there are various organs which might get the organ function might get jeopardized. So how do we do the iron overload monitoring? The iron overload monitoring is regularly done by measuring serum ferritin. It is an indirect marker of total body iron. The target is to have less than 1000 nanogram per ml. This is ideal. Currently, with the advent of therapy using deferoxamine, the serum ferritin level is now reaching as low as 450 to 350, which is like normal individuals like us. This serum ferritin has to be monitored every 3 months or 4 months, or while starting therapy, it should be monitored every month. Then we have got a very good tool in our hands now. That is the MRI of the hepatic and cardiac MRI. It can indirectly measure the iron content of the liver and that of the heart. The ideal LIC, that's a liver iron concentration by MRI, which looks like this. It should be less, around 2 to 2.5 milligram per gram of dry weight of liver. Before, what we used to do is we used to have a biopsy of the liver and then measure the iron content of the dry liver tissue. But that is no more required now. It can be done annually in transfusion dependent patients. Or when you are in doubt that the serum ferritin level is either too low or too high, it is not correlating with the phenotype of the thalassemic individual, you can go ahead and do a liver MRI. A cardiac MRI is again required if the R2 the T2 status of the cardiac heart resonance is less than more than 20 milliseconds. It is absolutely normal. And then from the age of 10 years, it can be done either annually or every 2 years, every 4 years. That depends on the patient, but this is available. Fibroscan, this measures liver stiffness, and the echocardiography to measure cardiac function is also available. That should be done by a person who's a cardiologist but has got knowledge about thalassemia, or an entire team approach where a cardiologist, an endocrinologist, a gynecologist, along with a thalassemiologist participates and decides how to take along a patient normally on a path by which the management is the best for that individual. I'm not going into the details of this because this can be taken up as another standard lecture. I'm not going into this either. So what are the complications of iron overload? The complication of iron overload in broad is the cardiomyopathy from iron. So iron deposition is there in the myocardium, which gives rise to oxidative stress that leads to dilated cardiomyopathy, that is due to the anemia. Both of them occurring together will have a restrictive physiology in early stages, and then there'll be hypoxic cardiomyocyte, which will show very limited regeneration, ultimately leading to cardiac failure. Other cardiac manifestations can be arrhythmias, heart failure, pulmonary hypertension. This pulmonary hypertension mainly occurs in non-transfusion dependent individuals and also in post-splenectomy patients. This is also sometimes precipitated by long-term hydroxyurea therapy. So we should be very cautious. There might be pericarditis and there is every chance of sudden cardiac death. So what should we do? We should refer a patient suffering from thalassemia long-term, when the person is on long-term transfusion therapy and on chelation therapy, for cardiac monitoring under a trained cardiologist who understands thalassemia also. So there the cardiologist will do an ECG, echo, then a T2 star, and then an R2 star from the MRI, and the person will ultimately tell you if the heart is normal or not, if the person wants to give some medicine from the cardiac point of view, and if the heart iron is very high, then a thalassemiologist should consider whether to give intravenous continuous iron chelation by using desferrioxamine, or the person can be started on Kelford, that is deferiprone. Deferiprone is a very potent agent for chelating cardiac iron, and also the person can be started on deferasidox. So that decision has to be taken by the cardiologist and the thalassemiologist together. Hepatic complications I'm not going into, but the prevention and management is very important. Again, a gastroenterohepatologist has to be there in the team, because today, if there is a high iron overload, that can be taken care of by a thalassemiologist. But if there is infection with hepatitis B or C, which is not very uncommon in this part of the country, that requires very specialized antiviral therapy, which should be done under the supervision of a hepatologist. And I have never seen a transplant being done in my life till date in at least this part of the country. But again, hepatitis B vaccination, hepatitis A vaccination has to be done. Fibroscan, whether to be done or not, has to be decided again upon by a hepatologist. But an LIC, the liver iron concentration monitoring, which is again a gold standard, should route our therapeutic eye to whether to start an intensive chelation therapy, or the chelation therapy regime requires to be changed or not. That call will be taken by a thalassemiologist. Iron overload can also lead to hypogonadism, growth retardation, hypothyroidism, and also diabetes mellitus. Most of the patients who has got a cardiac iron overload will have all these. Will have hypogonadism, will have growth retardation, will land up ultimately with diabetes mellitus, and might or might not have hypothyroidism. In my career, I have seen plenty of patients who have been started on hydroxyurea have some kind of hypothyroidism in their lifetime, and they have early hypothyroidism. So if a patient is being put on hydroxyurea after about 9, 10 years of age, the person should be monitored using free T4 and TSH to see if the person is developing hypothyroidism or not. Here, the most important part is in a normal individual, endocrinologists generally wait to see that the body's physiological function is if it is able to correct the hypothyroidism or not. But here we don't wait. We replace the levothyroxine to such an extent that the body does not have to work more. So the compensation of the body will not take place in a thalassemia because the circulation is not normal, the chelation is not normal. Otherwise, the person does not have hypothyroidism. So here to normalize everything, a normal working thyroid is very important. There we should start with supplementation of levothyroxine. But again, that's an individualized approach. It is a combined approach between the endocrinologist and the thalassemiologist. We've also seen hypoparathyroidism and adrenal insufficiency, but adrenal insufficiency is very uncommon in thalassemics. And in my career, I have just seen 2 cases. Others were all normal as far as that was concerned. And hypoparathyroidism, it is not very uncommon, but it is comparatively uncommon when we compare it to the other endocrinopathies. So ideally, what should be done from the age of 10, annual screening using fasting blood glucose, thyroid stimulating hormone, free T4, calcium phosphate, and parathormone. And pubertal assessment should be done by Tanner staging from the age of 10 to 12. LH, FSH, estradiol, and or testosterone as the requirement may be. Growth velocity monitoring, height and weight, and especially if the patient is on desferrioxamine, then the sitting height should be measured every 6 months. DEXA scan for bone density should be done from starting from the age of 10 to 12 years and repeated every 1 to 2 years as the requirement arises. Osteoporosis and bone density, I'm not going into the details. Again, this is a very specific approach. This also justifies the combined approach or a team approach of an orthopedic surgeon, an endocrinologist, and a thalassemiologist. If you talk about a team which is going to take over the management of a thalassemic, you cannot leave out any field of medicine. All the field specialists have to come, they've got to join hands and they've got to treat it together. Other complications and comorbidities might be infections. There might be thromboembolic episodes. Thromboembolic episodes are very common in case of non-transfusion dependent thalassemia, especially post-splenectomy. There are chances of pulmonary embolism, deep vein thrombosis and stroke. There is platelet hyperactivation and hypercoagulability, and prophylaxis in the form of aspirin or in the form of clopidogrel or a combination should be given, especially to patients who are of post-splenectomy status, number one. Number two, if a patient has been put on luspatercept or lozosda, that pushes up the thrombocyte count. There is thrombocytosis, platelet is produced in excess. They also should be monitored as far as thromboembolic events are concerned. A person who has been put on thalidomide should always routinely be put on the aspirin dose. This again should come under the purview of thalassemiologists and it should not be left out. If there is sign of hypersplenism, the spleen can be reduced to a certain extent with hypertransfusion. If the hypertransfusion cannot reduce the size of the spleen and the person's spleen is actually eating up the WBCs and the platelets, causing thrombocytopenia like leukopenia or thrombocytopenia, the person should be having the spleen removed, because a person who's having a low WBC, low platelet count is at risk of a bleed anywhere. So that splenectomy should be done, and splenectomy requires very specialized surgery. Today, specialized surgery for spleen is also available by doing a laparoscopic surgery, but a person should be having vaccination against pneumococcal, Haemophilus influenzae, and meningococcal. These 3 vaccinations have to be given. The person has to be given prophylaxis with penicillin and also prophylaxis with the aspirin-like agents after splenectomy. So this is very important. Some psychological impact is always there, and that should be taken care of by a psychologist. So the key takeaways, the hemoglobin, I'm not going to go into much of a detail. Uh, I have already talked about all these cases. The last point is important. Prevention through carrier screening and genetic counseling can nearly eliminate new cases, as proven by Cyprus and Iran. This is the take-home message that we should take from here. But the following sections are important. So what is the survival with modern therapies? So the key factors is we have given optimum transfusion, we have given regular and optimum chelation, we have given the person safe blood, we have given the person non-alloimmunized, that is the blood which is given after phenotypic screening and phenotypic matching, blood through a leukodepletion filter or leukodepletion, not leukodepletion at bedside, that is leukodepletion at the time of collection. If this kind of blood transfusion is given, which is properly tested for all the TTIs, and the transfusion maintains the pre-transfusion hemoglobin at and around 9.5 to 10 gram per deciliter, there is optimum chelation. There is no serum ferritin level which has exceeded 2,500 in the entire lifetime of that individual, with the cardiac and hepatic iron remaining normal. We have seen with our experience that a person attains normal growth, normal puberty, and everything else is normal, such that a patient contributes actively to the social and economic growth of the country. These are the glimpses of various patients whom I have treated. You can see this is a lady patient. This is a hemoglobin E beta thalassemia patient. This is a sickle patient. This is a beta thalassemia patient. Her age currently is 48 years. This is the girl which is whose age is 38 years. She is a beta patient. This is a beta patient. This is a E sickle patient. This is a E beta patient, and this is a beta patient. So all of them, you can see that they have got normal height, no, almost normal weight. They have been successful. These people are doing jobs. She's in a job. She's in a job. She's in a job. This boy is doing some private business. This boy is also doing business. She's a housewife. This girl is also a housewife. That in details, and the average and the age, as I told you, of this individual is 48 years. So she came into the picture of treatment of thalassemia when just Desferal infusion was available. And now she takes just Defracerox, and her serum ferritin is 1100. So if it can be maintained for these kind of individuals, this story can come true for every one of the doctors treating thalassemia. Now I'm going to talk about curative therapies. Why I showed you that picture before is there is no harm if a person cannot afford a curative therapy, because today with optimum management, the curative therapy still has risks, but the non-risk approach is towards management and optimum management of thalassemia. But that doesn't mean a curative therapy will not be approached by a thalassemiologist. So what are the curative therapies today? This is a boy. This is a picture which has been taken from 2007. He got a transplant, hematopoietic stem cell transplant from his sister in 2009. He was not cured. There was a graft rejection. He takes transfusion every 10 to 15 days and maintains a hemoglobin. And this is his picture today. This picture is 2 years old, when he got a chance to study in the one of the most prestigious institutes of this nation, that is Indian Institute of Technology, Bombay. That's IIT Bombay. He ranked 87 in the national entrance exam for engineering. So we attempted, we failed. But our target should be maintaining a thalassemic individual with optimum health status in whom a transplant has not been attempted, or if a person's transplant has been done, and even if the person is a failure, the transplant hasn't worked. But now let us see what are the different types of transplantations. So there are three types of transplantations today. One is the matched sibling donor, that is the sister or a brother giving the normal hematopoietic stem cells. This gives us the best outcome, but only 25 to 30% of the patients have one. Next comes the matched unrelated donor, which is the mud transplant. This goes on to expanding donor registries, and this is making transplant possible in plenty of other individuals. Today, the haploidentical transplant has taken the field by storm, where either the mother or the father's mobilized peripheral blood is used for transplant of the patient. And also, for matched sibling donor, the transplantable material might be bone marrow, might be peripheral blood, might also be the umbilical cord blood, which has been stored at the time of birth of the sibling. So a matched sibling donor's cord blood with the haploidentical mother or father parents' peripheral blood can have a combined transplant, and that protocol has also become successful. There is a conditioning regime which is low reduced in intensity, busulfan cyclophosphamide with antithymocyte globulin, that is reduced in intensity for older and high risk patients, that is also giving rise to better successes. In India, the Thalassemia Bal Seva Yojana is now giving 10 lakh worth of money for BNT in 17 impaneled centers. Optimum timing of transplant should be when a child is 2 to 7 years of age. That is when no organ damage is possible. For all beta thalassemia major patients, a matched sibling donor transplant should be offered if a matched sibling donor is present. There should be intensive chelation. The hepatitis infection should be treated, and others should be done. But what are the risks? Acute GVHD or graft versus host disease occurs in about 15 to 25%, even in the best of matched sibling donors. Chronic graft versus host disease occurs in 5 to 15%, even in matched sibling donors. Graft rejection or graft failure might happen in 5 to 10%, and the transplant related mortality is between 5 to 10% with the best of therapies. This graft rejection or graft failure of 5 to 10% is absent with autologous gene therapy approaches. Again, I'm not going into the details. This is another success story where you can see this is the child who was suffering from thalassemia. The father had actually planned a particular pregnancy. They did not want to have a child who would not be a HLA match, and there would be a risk of having either a normal or a carrier or an abnormal child. So they went in for a IVF. In the IVF, there were plenty of embryos which were produced. There were actually 15 embryos that were produced. Out of the 15 embryos, a particular test that was done, which is known as PGD or pre-implantation genetic screening with pre-implantation genetic diagnosis. For this particular case, a non-invasive PGM was done, where the fluid in which the embryo is being grown, the media got tested without actually taking out or doing a cell biopsy. The embryo which was transferred was actually of an embryo which was a carrier and was 100% HLA matched. That embryo was transferred to the mother, and this baby girl was born. Last year, on the 17th of September 2025, the mother's haploidentical stem cells and this baby girl's fully matched umbilical cord blood was transplanted to this boy. And this is the picture which was taken when the boy was discharged in last November, that is November 2025. After full engraftment, he is now coming out of the transplant unit that you can see. Though this is actually another success story which has happened and is possible. Here sometimes being a thalassemiologist and a transplant physician pays off by playing the god, where we could actually have a baby, the baby being normal as well as HLA matched. So after that, we come to the gene therapy era. So there are two types of gene therapies. What in gene therapy, what do we do? There is a defect in the gene. So the defect in the gene can be cut off and a normal gene can be inserted. It is sounding like it's very easy, like a Lego game, but it is not that easy. So the Betty Baglow gene, this autotem cell that was done. Actually, I cannot pronounce this very well. I am well versed with Zinteglo. So the Zinteglo project, when it was conceived, a new beta globin gene was synthesized individually on an individual basis, and it was actually genetically engineered, and it was put inside the hematopoietic stem cell, correcting the gene sequence. And these hematopoietic stem cells were then cultured. Once adequate hematopoietic stem cells having this particular gene corrected version hematopoietic stem cells were there, they were harvested. And the child who was suffering from thalassemia, his bone marrow was totally ablated, and this particular hematopoietic stem cells was given. And slowly these gene corrected cells took over the hematopoiesis, and the child started producing normal blood, normal hemoglobin containing blood. The problem is, as this was approved by FDA in 2022, it was later withdrawn in the US and the EU because from the market because of commercial non-viability, because this was a very expensive approach, because you had to individually make those hemoglobin transcripts, the hemoglobin transcribing transcripts, put it into a packet, then deliver it into a hematopoietic stem cell. Not all will take, some takes, then you got to select those cells, take it out, culture them artificially, then grow them to a particular amount where it is going to make a difference, where it will grow, and then you do a transplant. So it was very expensive. So next came the Casgevy project. In the Casgevy project, CRISPR-Cas9 was used, where one of the sleeping genes, which switches off the fetal hemoglobin, which is the normal hemoglobin when we are in our mother's womb, it gets actually switched off when we are born, after we are born, and completely switched off, almost completely switched off when we reach around 18 months of age, was switched on by this CRISPR-Cas9 editing. And the children who were transplanted using this Casgevy transcript, they started synthesizing fetal hemoglobin very well. And now they have been approved by the FDA, and the cost is not very high as far as the curing is concerned. It is there in the US. I think India is also trying under the Make in India project to have their own transcript, to have a gene therapy. Already I know that there is a gene therapy which is coming out for sickle cell disease. I don't think that time is very far away from when gene therapy, Indianized gene therapy, would be coming out for thalassemia itself. I'm not going into detail because I have already explained this. This also I've explained. So what is the comparison between allogeneic hematopoietic stem cell transplant, gene addition, and gene editing? There is a donor needed for each hematopoietic stem cell transplant, whereas the child is his or her own donor in case of gene therapy. Transfusion independence is about 80 to 90%, whereas it is 90% in case of the Zynteglo and 98.2% in case of Casgevy. Conditioning regime is almost the same. Follow-up has been for 30 plus years, whereas that for the Zynteglo is 10 years and for Casgevy is up to 4 years. The cost is in lakhs for allogenic, which will be between 12 to 50 lakhs for allogenic HSCT. For Zynteglo, it is about 2.8 million US dollars, and that is why it has been withdrawn from the market. And for Casgevy, it is around $2.2 million. Age at which the best results occur in case of HSCT is below 7 years. For Zynteglo, it is more than 4 years. And for Casgevy, it is more than 12 years. Now we should turn our attention not towards maintenance, not towards gene therapy, but towards prevention and screening. So population screening is the only approach, and the ideal genetic screening should be there. There are several approaches. Universal antenatal HPLC screening, that is the FOGSI GCPR 2025, it has been launched. A premarital screening has also been launched in high prevalence areas. Cascade family screening we always do for index cases. School and college-based screening programs, it was launched sometime, but now it is being abandoned because the children who get screened during their school or college years, mostly they forget their reports. And the targeted approach, every untested woman should be screened by the first trimester of pregnancy. This is the take-home message. Genetic counseling should also be done. We should understand and note that if there are two carriers who have got married, there is only 25% chance in each pregnancy that they might conceive a thalassemic child. If at around 11 weeks of pregnancy or 12 weeks of pregnancy, the person should undergo a testing known as prenatal testing in the form of chorionic villus sampling or amniocentesis in later months of pregnancy. It is going to screen out if the fetus is normal or the fetus is carrier or patient. If the carrier are normal or the fetus is a patient. If the fetus is a patient, then therapeutic abortion option should be given to that particular individual, and the fetus gets aborted. If you don't want to take that option, you've got the option of doing a PGM, or you can go in for donor gametes where even a PGM is not required. But psychological support and informed decision making is most important, and normalized screening within the community health conversations is very important. I'm not going to go into the details of this. I've already spoken about this. This is most important, universal antenatal HPLC screening. It is recommended by FOGSI under the Project Mukta in the first trimester. Premarital preconception carrier testing in high prevalence communities, and cascade family screening when a carrier or an affected individual is identified. So all the government and NGO programs, National Health Mission, Thalassemia Bal Seva Yojana for transplantation, Project Mukta for universal antenatal screening, DKMS India is now having a donor registry, CIRC expanded screening drive and campaigns in and around Delhi. But the challenge is that even uneven program coverage, there are cultural barriers, and there is carrier detection still remain as significant gaps. Future directions would be towards next generation screening, novel pharmacotherapy, AI technology. It is coming in everywhere. It is also going to come in screening, in interpretation of iron reports, in planning certain missions, and other things also in case of therapy. And access and equity, this is most important, not only for the gene therapy, but also for as simple as if I'm going to give a hydroxyurea or a folic acid as a medicine, it should be available to every individual through government sponsored or government hospital programs. A chelation therapy again should be available to everybody. So I'm going to end my talk here. Here I have taken a picture long back, about 5-6 years back, where I could not capture the rising sun. But you can see that the sun is hidden somewhere behind the horizon, very early wee hours of the morning, where the sky has become red. So today, I think, as far as hemoglobinopathy and thalassemias are concerned, we are standing at this place, at this juncture, where though the sun has not risen on prevention, on management, or on cure, but the red light of the sun or the sunbeams are visible through the horizon. So we just have to wait that little bit when we can see the sun. And that day is not far away when India will have certain programs, because India very, very badly requires a genetic profile by which we can screen for all the types of beta hemoglobinopathies at one go, and it will be cheaper than an HPLC. We can have a gene panel. We are working towards it. We should have our own program by which we'll be able to construct a transcript of a new hemoglobin gene and how to put it into a hematopoietic stem cell, how to get that correction done and grow it in proper amounts, not depending on the culture media, not depending on the growth factors that are produced abroad, but we produce it here. And we produce adequate amount of stem cells tomorrow to make gene therapy possible. So I hope in another 5 to 7 years, what I'm telling you today, you will see tomorrow. And that tomorrow is not far away. So the sun is there behind the horizon, but we'll just have to wait that little bit for it to rise. Thank you very much for giving me a patient hearing. So though the take-home message here is, though prevention is better than cure, but when cure is needed, science would be delivering. Thank you very much.
Thank you so much, sir, for such a wonderful lecture. And it actually had encompassed like everything which was sir, because there is very little time and we have overshot the time. So we would just how often are blood transfusion needed and what is the target hemoglobin level that we are aiming for, and how often ferritin levels should be checked and when should we perform an MRI, and which iron chelation medication works best. So yes, sir.
Okay, I mean, that question is not one, Dipanjana.
No, I know, sir,
That's
but
that's
we
like
are
it's a
really
huge.
running out of time.
Yeah,
That's
yeah,
why.
I'll just start. So number one, the target hemoglobin for a transfusion dependent thalassemia patient should be between 9.5 to 10 gram per deciliter pre-transfusion. So once a person gets a hemoglobin of 9.5 or 10, the person should be going in for a transfusion. The target hemoglobin should be around 14 to reach post-transfusion. That is your first question. Second question was how frequent.
The
So
ferritin
this answers
levels,
that. Yeah,
how
ferritin
often the
level.
ferritin levels?
The ferritin level should ideally be monitored at the start of a chelation therapy every month, but it's very expensive. So we should do it every 3 months to 4 months. But that again depends on what is the ferritin level like. Today, if the ferritin level has come down to 1000, and if I'm worried about the toxicity of the chelating agent, I'll be doing it every month. Or if the person has got a ferritin level of 10,000 or 5,000, there the high ferritin is a problem and I'm giving intensive chelation. There again, it should be done every month. But if a person is having a ferritin of around 1,500 to 3,000, it can be done every 3 to 4 months. That's question number two. Question number three is your MRI. MRI, what I personally do, again, a recommendation is there from the TIF, which says that it should be done every year. But an MRI in one of my hospital costs about 7,500 to 8,000 rupees. When I do MRI is when I have encountered a person having a ferritin of 1,000, because 1,000 is walking a tightrope. Either you stop the chelation or you don't stop the chelation is going to depend upon what is the organ iron load. So there you require to do and take a decision whether to continue with the chelation therapy, reduce the dose or not. And the second is when you encounter an abnormally high iron load, there you require to do it. But if a person has got a cardiac MRI which is high and a T2 star of 10, 12, there you require to do it at least every 6 months to 1 year, so that you know that really that particular iron load is reducing. What was the fourth question? I forgot.
So, which iron chelation medication is best, oral versus injectable, and which side? What are the side effects like joint pain, stomach pain?
Okay, so the best is today deferasirox. Deferasirox dose varies from NTDT. It starts from 5 milligram per kg. You can go up to 40 milligram per kg depending on the. You can cater the iron overload and the transfusion load, and you can monitor the particular dosage. You start from 5 milligram, you can go up to 40 milligram. Ideal chelating dose is around 25 to 35 milligram. That is good enough. This particular medicine you can tag with Kelford, that is deferiprone, but deferiprone should be dealt very cautiously because that gives rise to arthritis, joint deformities. If a person, and it can give rise to catastrophic events like agranulocytosis, WBC platelet might go down. So that requires to be monitored at least every month. And if a person is on deferasirox, that is again an oral, there two things should be monitored. Four things should be monitored at the start of therapy. vision with a retinal photograph, auditory testing, kidney testing, and liver testing. These 4 testings should be done. After that, if everything is normal, the liver testing and the kidney testing should be done every month. What I personally do is a liver function test, a serum creatinine, and I do a microalbumin creatinine ratio with a complete hemogram every month. And that is good enough to give us a picture of whether to continue or not. Frankly speaking, though Desferal was a very drug and still is a very good drug, the fright of taking injections daily is the main deterrent towards compliance. And if you don't have compliance as far as chelation therapy is concerned, the thalassemic individual will not stay well. So better to go with oral. But you can give on individualistic approach, you can give the different medicines in combination and you can monitor the different side effects.
Thank you so much, sir. We don't have much time. We would have loved to hear more, but we have already overshot by 20 minutes. So we will close here. Thank you to everyone who joined. This is also available as a YouTube video for anyone who can watch, who would like to, have these reference points or watch later. So we please stay tuned for our next session as well. And we thank Dr. Prosanto Kumar Chowdhury for delivering such a wonderful lecture. So, and very good evening to everyone. And thank you for joining. We hope to bring you more informative series lectures henceforth, as we are bringing up. So with that, we say thank you and bye-bye.
Thank you. Bye-bye.
Bye.